Welcome back to IJGC Conversations and to our December Editor's Choice episode. Today, we are diving into several recent publications that really caught our attention. I'm Itziar Villagrá, joining you from Donostia University Hospital, Spain, and I'm thrilled to be here with my colleagues.
Hi everyone, I'm Joannie Neveu from Memorial University, and I work at the Health Science Center in St. John's, Newfoundland, Canada.
And I'm Mathilde, joining from Oncopole Claudius Regaud in Toulouse, France.
Great to be together again, and we're kicking things off with a massive real-world ovarian cancer study.
Exactly. And Mathilde, why don't you introduce this heavy hitter for us?
Absolutely. Our first paper is the SUROVA study, Global Real-World Treatment Strategy and Mortality Risk Prediction in Advanced Ovarian Cancer. The first author is Luis Chiva from the Cancer Center Universidad de Navarra, Madrid, Spain.
The SUROVA study is incredible for its scale. It collected data from 174 centers across 55 countries. Itzi, what was the primary objective of this huge global retrospective cohort?
The main goal was to compare the 5-year overall survival between primary debulking surgery versus neoadjuvant chemotherapy, followed by interval surgery in patients with FIGO stage 3B, 4B epithelial ovarian cancer.
Now, before they did any statistical adjustment, the raw data show PDS was superior, right? Median OS was 71 months for PDS versus 55 months for neoadjuvant chemotherapy. But they noted significant imbalance in baseline variables. How did they account for that? They used propensity score matching to balance 7 baseline variables, including age, race, ECOG performance status, and FIGO stage 4 disease. After matching 1,524 patients, the overall survival difference between the group basically disappears.
Right. In the matched cohort, median overall survival was 67.2 months for primary debulking surgery and 65 months for neoadjuvant chemotherapy, with a hazard ratio of 1.0 and a p equals 0.98. This is crucial because it reinforced the non-inferiority of neoadjuvant chemotherapy globally, aligning with some previous randomized trials. But the real finding was in the subgroup. What did they find regarding ethnicity?
Ethnicity was a major factor that modified the treatment effect. Among the Asian patients, which made up 14% of the matched cohort, outcomes consistently favored neoadjuvant chemotherapy with a hazard ratio of 0.31. The authors suggest this might be related to pharmacogenomic differences that confer greater platinum sensitivity.
That's a huge difference from the non-Asian group. For non-Asian patients, the survival curve crossed. Outcomes were similar for the first 2 years, but PDS was associated with superior long-term survival beyond 24 months, as a ratio 2.02 and p inferior of 0.001.
But we need to highlight the caveat that primary debulking surgery survival benefit was highly conditional. What did the study prove about complications and survival?
It proved that complications neutralized the benefit of surgery. The most favorable outcomes were seen only in patients who had primary surgery, achieved complete resection, R0, and had no complications. For this highly selected subgroup, the median overall survival was not reached. This subgroup represented only 27% of the entire study population.
And if a patient had PDS and developed a complication, their median survival dropped from 73 months, no complication, to just 46 months. That 46 months survival was the same median overall survival observed in the neoadjuvant chemotherapy group with complication. The presence of high-grade complication, grade 3, was associated with the shortest median survival, 45 months.
So the global consensus is primary debulking surgery is only better if you're certain of surgical success in terms of cytoreduction and complication avoidance, which supports individualized decision-making based on perioperative risk and ethnicity.
Moving to endometrial cancer, let's discuss surgical staging. Mathilde, tell us about the Sentinel lymph node study.
This is the outcomes of the Sentinel lymph node mapping algorithm for patients with locally advanced endometrial carcinoma. The first author is Alan Guang from the University of Pennsylvania Division of Gynecologic Oncology, Philadelphia, USA.
This paper addresses a key uncertainty: the safety of the sentinel lymph node biopsy algorithm in patients with locally advanced disease, FIGO stage 2 and 3B, 2, 3A, and 3B. Basically, disease involving the cervix, vagina, ovary, and perimetria. Since these patients have a higher incidence of lymph node metastases, there was concern that sentinel lymph node biopsy algorithm might be inferior to systemic lymphadenectomy.
Using the National Cancer Database, how did the authors compare the Sentinel lymph node algorithm versus systematic lymphadenectomy, defined as removing at least 20 nodes?
They analyzed 2,108 patients. The crucial finding was that the rates of lymph node metastasis detection was comparable between the group, 35.8% for systematic lymphadenectomy and 32.6% for sentinel lymph node biopsy, p equal 0.27.
And that comparison held true for survival, didn't it?
Yes, there was no overall survival difference between systematic lymphadenectomy and sentinel lymph node biopsy with a p equal 0.16. The 4 years overall survival rates were 71.5% for sentinel lymph node biopsy and 73.9% for systematic lymphadenectomy, even after controlling for co-founders.
That confirms the oncologic safety. Joannie, what about the patient recovery aspect? What's the clear practical benefit of using the Sentinel lymph node biopsy algorithm even in this locally advanced setting?
The morbidity benefit was notable in that study. As per this group, the patients who had sentinel lymph node biopsy were significantly more likely to be discharged within 1 day of surgery, 78.6% versus 66.4%, and this was statistically significant. This suggests that by avoiding systematic lymphadenectomy, we are decreasing perioperative morbidity without compromising lymph node detection or survival for most locally advanced patients, making it a viable staging option.
Our final paper shifts focus to cervical cancer and refining multimodal treatment toxicity. Itzi, can you introduce the detail on this one?
Certainly. This is the evaluation of toxicity after radical hysterectomy or trachelectomy and postoperative pelvic intensity modulated radiation therapy with concurrent chemotherapy for cervical cancer. The first author is Beryl Manning-Gist from Emory University School of Medicine, Department of Gynecology and Obstetric, Division of Gynecologic Oncology, Atlanta, USA.
Current guidelines favor definitive radiation over radical surgery if the patient was likely to need postoperative chemoradiation, largely due to combined treatment toxicity based on older radiation techniques. This study specifically looks at whether modern IMRT, intensity modulated radiation therapy, changes the toxicity profile.
They analyzed 91 patients with early stage disease who underwent radical surgery followed by adjuvant intensity modulated radiation therapy and concurrent chemotherapy. Izzy, what was the incidence and type of acute toxicity?
Acute toxicity was extremely common. 100% of patients experienced some acute adverse event. The most frequent were fatigue, 85%, and gastrointestinal issues, 81%, specifically diarrhea in 81% and nausea in 80%.
But let's be critical. The acute toxicity was manageable. Acute grade 3 toxicity occurred only in 2% of patients involving gastrointestinal symptoms and fatigue. The median acute toxicity scores worsened during treatment for hematologic fatigue and GI toxicity, but remain low grade.
What about the chronic effects, which are the long-term concerns following combined therapy?
The chronic toxicity profile was very reassuring. Chronic toxicity, which is defined as persistent symptoms for more than 6 months after the treatment, were reported by 57% of patients, mostly chronic vaginal symptoms, which was a third of the patient. However, the severity was extremely low. The authors observed no long-term grade 3 bowel toxicity or radiation-associated secondary malignancy.
The only chronic grade 3 toxicity reported was lymphedema, which required a lymphovenous bypass in one patient who had a full pelvic lymphadenectomy. The acceptable toxicity rate suggests that IMRT allows providers to continue to offer radical surgery for appropriate candidates, even if subsequent adverse pathology, like positive nodes, which occurred in 73% of the cohort, necessitates postoperative IMRT.
Essentially, IMRT allows us to capture the benefits of surgical staging and resection without incurring the devastating chronic side effects that defined historical chemoradiation combination.
That's interesting. However, we still need to be cautious as we may not have a significant increase in toxicity, but we have no prospective data suggesting survival benefit.
So, we have three powerful messages today. In ovarian cancer, individualized care based on ethnicity and complication risk, Surova. In endometrial cancer, the safety and reduced morbidity of sentinel lymph node mapping for locally advanced disease.
And in cervical cancer, the finding that modern IMRT makes multimodal therapy far more tolerable than previously thought, removing a major impediment to offering radical surgery upfront. This is definitely material that change how we counsel patients starting this week. Thank you to all you listeners to tuning in.
We encourage you to seek out these excellent articles for more in-depth information. You can find them in the International Journal of Gynecological Cancer. Thanks for joining us, and we'll catch you next time. We'll be back soon with more updates from IJGC.